Hi, my name is Jade Garrett, and today I'm going to be presenting my interactive case study with you regarding pediatric and adolescent mental health. So, the history of this presenting illness, or how this patient presented, is a 12-year-old Caucasian male, and we're going to refer to him as JM throughout this case study. Presents to the clinic with his father and stepmother for a 9 a.m. follow-up visit after a recent 8-day inpatient psychiatric stay. JM was admitted to an adolescent psychiatric unit following a suicidal ideation with a plan to cut his throat after his father and stepmother found him holding a knife to his own throat. He attempted to jump out of the vehicle on the way to the hospital, and once they made it to the hospital, he became angry with his father and stepmother, stating, "I just don't want to live anymore without my mom. I hate you both." He was argumentative but cooperative with staff in the ER. He was discharged yesterday with the intent to start a partial hospitalization program, or PHP, today, and that he is currently on a safety plan. He appears well dressed, tearful, quiet, but overall cooperative with today's assessment. He is currently taking 50 milligrams PO of olanzapine every night and would like to continue the medication at this time until in more of a routine to better evaluate effectiveness of the medication. He's provided a PHQ-9 and GAD-7 screening form to complete prior to the provider entering the room. So his past medical history consists of the following. So he is not allergic to anything. As we previously stated, he is on the 50 milligrams of olanzapine. He has not had any prior medical hospitalizations, any surgeries, no history of head traumas, no medical diagnoses, no substance use. He's up to date on all of his vaccinations. His birth was uncomplicated, and he reached all of his milestones appropriately and on time. Father denies any sort of physical therapy, speech therapy, occupational therapy, and reports that overall he had a very normal childhood. He was diagnosed with depression during his inpatient psychiatric stay. And again, this was his first inpatient admission. So, his family history. He is an only child. His parents divorced when he was 6 years old, and he primarily lived with his mother in New York until approximately 6 months ago when he came to Nashville to live with his father and his stepmother. Prior to moving, he saw his father about once a month for the past years. Father reports that overall they maintained a good relationship and spoke daily between their in-person visits, and that JM knew his his stepmother prior to his move. 19 days ago, JM's mother passed away from pancreatic cancer at the age of 41. Father reports that his medical history includes high blood pressure, and then other than the pancreatic cancer from mom, there is no further medical history for either parent. Um, Mom's father had a stroke at the age of 80, and then dad's mother has type 2 diabetes. That father states as well controlled with diet. There's no family history of heart conditions beyond father's high blood pressure and grandfather's stroke, and then there's no family history of heart attack, lung problems, nerve or neurological conditions, any mental health conditions, and there is no addiction history. So he, like we stated in the beginnings, lives with his father and his stepmother, as well as their one dog. Dad works from home as a business owner, and stepmom works at the local elementary school with children with special needs. JM is in seventh grade and overall is an AB student without any difficulties at school. His favorite subject is science, and he does not enjoy English. He plays multiple sports, and when he grows up, he wants to be a professional baseball player for the New York Mets. He's able to list many friends from New York, but reports that he only talks to them on occasion now, as those friendships have been drifting apart since moving here. He has met some kids in his class and some kids on his teams, his new sports teams, but reports that his best friend right now is another boy currently on his baseball team. He eats a nutritious diet with good varieties of fruits and vegetables, and overall, he's a pretty active kid per his dad. He has sports practice 4 nights out of the week, and on the weekend, he is frequently outside playing basketball or other sports. There's no tobacco or smoke exposure, no drug use, no substance use in the home, and patient has denied all of these as well. He has his own room and his own bed, but since the passing of his mother, he reports that he's had trouble falling asleep and staying asleep. And when he started the olanzapine, he reports that this has improved somewhat, and right now reports that he's currently getting 6 to 8 hours of sleep per night. So his psychiatric history, as we have discussed in this scenario, is very recent and it's very new. So there's no family history. This was JM's first psychiatric inpatient hospitalization, and it was an 8-day inpatient hospitalization following suicidal ideation with a plan and intent to cut his own throat. He had not previously expressed any suicidal ideation to his father or his stepmother, but his father did express some concerns after his mother passed away, just stating he never seemed sad, stating that he never saw him cry, and thought to himself that he might need to be monitoring him and watching him a little bit closer. Both father and stepmother report after his mother's passing, he became withdrawn and somewhat irritable. The school notified the father that JM was missing 3 assignments and that he seemed less involved in class than usual. The smallest thing seemed to set him off is a report from his stepmother, and she also reports that these behaviors were very minimal prior to his mother's passing, but now feels that she has to walk on eggshells around him. His coaches report to dad that they feel that he's either giving no effort at all or that he's super amped up and feels like that he's almost pushing himself too hard in practices. And when he is in those states of mind where he's pushing himself too hard, he almost becomes irritable and frustrated with his teammates, stating that they need to work harder. And this has all been occurring in the last 2 to 3 weeks since mother's passing. Father reports that he's been difficult to wake up for school in the morning. And now that we know that JM has had trouble falling asleep and staying asleep, this kind of makes a little bit more sense. So provider asked why he felt it was hard to get up in the morning, and he said he just stares at his ceiling for hours. And then when he finally would fall asleep, he would imagine his mom dying home alone. You review the PHQ-9 and GAD-7 that he completed, and his scores are below. And then this is an image of his self-reported PHQ-9 and GAD-7 scores. So I want you to take a second and look at this. I'm going to read the question and I'll flip back to this slide. So based on the screening form provided on the previous slide, what depression severity score would he receive? So mild depression, moderately severe depression, or severe depression. And I'll give you one more glance at his PHQ-9 form as well. And the top part is the PHQ-9 and the bottom is the GAD-7 for anxiety screening. So the correct answer is D, severe depression. You can see the numbers for the ranges indicated listed there. So him scoring a 24 would put him right in that middle of that 20 to 27 points, which is severe. So we want to just make sure with that severe category, especially coming out of an acute hospitalization, with a plan previously in play and the plan to carry out at home, that we just have a strong safety plan and a good safety protocol in place. So this is definitely going to require lots of interprofessional collaboration. So some big points that we want to do is we want to definitely make sure that we are accessing those records from his hospitalization. We want to make sure that we are able to see his progression throughout the hospitalization. We want to make sure that we are identifying any medications that he may have failed while he was inpatient. For instance, if they gave him a PRN medication and he did not have an appropriate response, or if they changed his medication based on any indicators that they saw in the hospitalization, we want to know that, as well as if there was any titration of his medication. Did they just start him out at 50, which hopefully that is not the case based on his age, or how slowly they titrated that up. So making sure that we're getting dad to sign the release of information form to allow his partial hospitalization provider, the mental health provider or us, and his primary care provider to all be informed in his care to ensure that any treatment modalities that we may be providing to him are not interacting or overlapping with anything else that he may be provided. So this could be especially important if he were to become ill and be placed on an antibiotic. We just want to make sure that there's no medication interactions, as well as making sure if he does become ill, that we're identifying the symptoms appropriately to his physical illness versus his mental illness, or if there's any overlap. And then this is the provider's first appointment with him, just that post-hospitalization follow-up. So reviewing any notes from his pediatrician if they have access. For this case, this the clinical setting that I was in, the pediatrician and the behavioral health specialist worked in the same office. So they were able to sign a release form there and then immediately access charts. So being able to review those pediatrician notes to see if there were any, to see one, if he established care in the office since he just moved here 6 months ago, but just making sure that we have an appropriate medical history, a mental health history, that everything that they reported has checked out, and then being able to share notes with that pediatrician again to make sure that we're having continuous care. And then a referral should be made for therapy once his PHP program is completed to help him transition from that PHP program and to continue to develop those ongoing coping mechanisms. Usually for those programs, they are able to transition into a therapy option within that program, but we definitely want to talk with him. We want to make sure that the parents are aware that he may not like the fit of the therapist that he is placed with, and then making sure that he knows that it's okay to voice those concerns and that if he's not comfortable with the therapist that he is following up with, that it's okay to change. So again, he was already diagnosed with depression. So this is his current diagnosis, which is major depressive disorder, a single episode in severe. The diagnostic criteria are listed. So according to the DSM-5-TR, 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous function. And at least one of the symptoms is either depressed mood or loss of interest or pleasure. So if we flip back to his PHQ-9, these 9 questions that you see on the top are actually correlating to the 9 diagnostic criteria. So if we see where he circled 3 in 7 categories, that would certainly put him in the diagnostic criteria for 5 or more. So again, 7 out of the 9 categories that he struggled with nearly every day. It's also important to consider bereavement. Given the acuity of his symptoms, he is certainly experiencing bereavement, but he is also experiencing a major depressive episode. And given the nature of the suicide attempt and that he had a plan, we definitely want to make sure that we're taking this seriously and that we know that he has resources and that this is a safe place to discuss those thoughts and feelings. And then he reports not feeling irritable, but based on the reports that we received in the history from father and stepmother, and then some of the school reports, it sounds like he is being a little irritable, but I would expect a 12-year-old boy to not necessarily recognize that within himself. So, question number 2. Which of the following would be the most likely additional diagnosis? Now, this is not necessary, but if the provider felt that it was necessary, which of these diagnoses would be most accurate to include just based on this patient today, the information that we have so far, and the time span? So that's your clue. So acute stress disorder, adjustment disorder with depressed mood, generalized anxiety disorder, or post-traumatic stress disorder. So the answer here is acute stress disorder. Based on his GAD-7 score of 12, there is a likelihood that if symptoms persist for more than 6 months, he could be diagnosed with generalized anxiety disorder. However, it seems like just the information that we've collected today, most of this has to do with the death of his mom, but it's also too important for us to recognize as well that this is a 12-year-old boy who not only lost his mother, he also had to move to a new city, he changed schools, and he's living with a different parent that he hasn't normally lived with. So those are all very big adjustments and very appropriate reactions to be sad and to be anxious and to have big feelings regarding all of these. Obviously, it is not appropriate that we are having these safety concerns. So we just want to make sure that we're looking within context when we assess these diagnoses, but this is definitely one that we could keep on the back burner if necessary. So going into the differential diagnoses, again, we already kind of discussed acute stress disorder, but the other ones are plausible potential differential diagnoses just based on the limited information that we have. And let's go into a little bit of why that is not appropriate. But before we do that, given that disruptive mood dysregulation disorder is on here, I wanted to ask a question to just see your general knowledge. So which of the following is not a correct diagnostic criteria of disruptive mood dysregulation disorder? Outbursts, either verbally or physically, that are inconsistent with the developmental level, outbursts occurring more than 3 times a week, outbursts that occur for more than 6 months in at least 2 different settings, or that their mood between those outbursts is mostly irritable or angry and it is observed by others, such as friends, teachers, and family. So it is actually C. According to the DSM-5-TR, the symptoms actually must be present for 12 months. So 6 months would be too short of a span, and then obviously, given the limited information that we have today and based on the presentation that the symptoms have been recently occurring within the last 2 to 3 weeks, this would not be an appropriate diagnosis for our friend JM today. So not a sufficient amount of time for diagnosis for disruptive mood dysregulation disorder. I also included on here the page numbers for the DSM-5 if you wanted to reference those. Adjustment disorder with depressed mood. So this is distress that a patient is experiencing related to multiple events or stressors, which he has absolutely experienced, but they can still be contributed or attributed to bereavement at this time. So typically with adjustment disorder, the symptoms have to occur within the first 3 months. However, given that he has a factor that does consistently coincide with the timing and with all of his other symptoms, and this does fit into a major depressive disorder diagnosis, this doesn't necessarily fit our patient at this time. Generalized anxiety disorder requires that symptoms persist for 6 months or more. So this is something that certainly could develop as we follow this patient for a longer period of time, or as we dig further into it, we are certainly looking right now at the death of his mother being the trigger point. But if we do a more thorough psychiatric evaluation and we discover that before he moved, he was already having these thoughts and feelings of anxiety, this could be an appropriate diagnosis. So post-traumatic stress disorder is another one that certainly comes to mind that I'm sure a lot of you were thinking of already. So this duration must be for more than 1 month. We're kind of just under that window right now with mom passing away 19 days ago, but this is definitely something we want to keep in our pocket, especially if PHP doesn't continue to be a good option, considering the acuity that he's already had an 8-day inpatient stay. We definitely want to make sure that if this continues to persist, that we're treating that appropriately. And then we kind of already discussed the acute stress disorder. Luckily for that, PHP and medication would both be inappropriate, as well as for generalized anxiety disorder. The SSRI, olanzapine, would also be helpful as well in treating that. So his treatment plan, as I kind of mentioned, with his PHQ-9 score being a 24, and given he has already had a suicide attempt or suicidality with a plan rather, we want to initiate a safety plan. So obviously he was discharged with the safety plan. We want to go over that again with family and with JM and make sure that they are both verbally consenting to this as well. We want to ensure that everyone has crisis hotline contact information. We want to make sure that this is posted in a place that everybody can see and everybody has access to. So this 1-800-273-TALK is the National Suicide Prevention Hotline. There is also a 988 phone number that you can call or text. So that's a number that many of the adolescent patients in our practice have been utilizing, or that we give to them because they can just save it in their phones, and it's 24/7. So making sure that both of those numbers are in phones and located somewhere that if he needed access to those numbers, he could get to them quickly. We're going to continue his medications as is based on the requests from dad that they want to continue to monitor and see what the PHP program outcomes are. And then we are going to go ahead and schedule an appointment for 1 month from today to follow up again in the office to evaluate the effectiveness of his medications. And then at that time, we can evaluate if a dose adjustment is necessary. Now, given the acuity of all of this, we also want to follow up in between. And because he's only 12, we can follow up with the parents, but we certainly want to make sure that we are getting input from him as well. So we will call the family and follow up in 2 weeks and get the updated progress during the PHP program and to see if we can provide any further resources as well. And during this time, we want to make sure that he is attending his PHP program, that we are starting to get the ball rolling in the direction of making sure that he has a therapist in place at the end of this program, and then as well as establishing a timeline for his PHP program. So that could be 1 to 3 months, depending on what their evaluation looks like. We want to continue to monitor for any side effects of the medication, and that can be started at our 2-week phone call because at that point he'll have been on it for 3 to 4 weeks. And then we certainly want to follow up for those side effects at the 1 month in office follow-up, and definitely making sure that we're educating parents and patient. He's 12 years old, and given that he was already in the hospital for suicidal ideation, we want to make sure that if he's having any of those thoughts or feelings, that he's making sure he lets somebody know immediately, given the black box warning of all SSRIs. And then we want to follow up and ensure that our records are received from his hospitalization and that we are communicating with anybody in the PHP program to make sure that if they do any changes, if they require any further recommendations, that we are also receiving that, and then we are communicating back to them how we can help. So prevention strategies. Obviously, in this situation, a little bit of anticipatory adjustment would have been helpful, but it also is in the past and it has already occurred. So we don't want to make anybody feel guilty for anything that they should have or could have done. But just in future, knowing that he was going to be moving, coping with the loss of his mother, it could have been potentially helpful to initiate the therapy process sooner. But again, this is likely not something that I am going to bring up with the family. They have all been through the death of this woman, and so bringing this up isn't necessarily something that is going to help that process. But should you come into contact with any patients that may be anticipating this or maybe received a terminal diagnosis for a family member, going ahead and initiating that process to referral for therapy and making sure that they have crisis hotlines and stuff like that. And then we are going to repeat the PHQ-9 and GAD-7 at the 1-month follow-up. And then more routine office visits until he is stable. So many times our patients are seen at 2 and 3 month follow-up, but given his age and the acuity, we definitely are going to do a 1-month follow-up as well as that 2-week phone call. And then just in general, early depression and anxiety screenings in primary care offices. So according to the USPSTF and the American Academy of Pediatrics, or the AAP, both follow the same recommendations that screenings for depression should begin at 12 years of age at those doctor's appointments. So this is, again, stressing the importance of communicating with his primary care provider and making sure that they are aware that he was inpatient for 8 days and that he does have a safety plan at home and that he has been seeing a medical professional and that he is on medication for these mental health concerns that he's experiencing. And then also recognizing that he is going through a true grieving process, and just offering that appropriate support. We're always wanting to offer comfort. We certainly want to make sure that he is safe, but then we also want to recognize that he has truly gone through many, many, many traumas, and that it is okay to feel all of the emotions that he's feeling, but that it's not okay to act on those emotions, that we want him here, that he is safe here, and that he is loved here, and making sure that he knows the environment that he is in is loving and supportive. And then this last one is just improving education and reducing mental health stigma. I feel like we are all aware of that. And this just needs to be worked on in every aspect, in the medical field, in the mental health field, in just adults and in adolescent populations in general. I do feel like with the advancement of social media, sometimes that's harmful, but also sometimes it's helpful. Certainly, we've seen an increase in cyberbullying, but we have also seen an increase in spread of awareness of adolescents talking about their mental health struggles and talking about the medications that they've been on and talking about their therapy processes. And that kind of lets kids know that they're not alone and that they're not the only one experiencing these processes. So it's important that we improve education across the board for all walks of life, in the medical field or out of the medical field. And then just a quick little side note, suicide is still the second leading cause of death in adolescent populations 12 to 18 years old. We almost got out of that, but we have not yet. And then I just wanted to include one last slide on the importance of family involvement. This last point is really important. So I feel like we are always very quick to say that parents need to be involved in the treatment plan and that they need to support and guide their child and they need to provide the education and be in family therapy. But if we note that the family is detrimental to our patients healing or growing in the pediatric populations, we need to work with our patients to identify another adult that can be this caregiver or this adult figure in their life during this process. So it's really important to know that it's appropriate that adolescent populations value privacy and independence. It's okay if they don't want that trusted adult to be their parent, but they do have to have a trusted adult that they can confide in if there is a safety concern, whether that's that 988 hotline or even 911 if they can't remember anything, or going to the nearest emergency department, the school guidance counselor, an aunt, an uncle, a neighbor, anybody that they feel comfortable enough to discuss, hey, I don't think something's right in my body, or hey, I'm having these thoughts and I need to let somebody know. Someone that they can trust to help them with the thoughts and feelings that they're having so that we know that these kids are safe. So I hope that you have enjoyed this presentation. I hope that you have learned something about pediatric mental health. And if you have any questions, please feel free to contact me. This is my list of references, and hang in there, everybody. We are so close to the end of the semester.